So in this chapter, we're going to cover the psychosocial complications for our brain injury population. So what are some factors that can impact the new onset psychiatric symptoms following the brain injury? They include age, gender, injury severity and location, premorbid psychiatric symptoms, and some social factors, for example, the financial stability or social relationships. So, to be more specific, how does injury severity impact the psychiatric symptom development? The results are pretty generic. It says there's a higher risk to develop psychiatric illness for mild or moderate to severe brain injuries. I think that's because most of the research results are either inconclusive, inconsistent, or they're just preliminary. However, the author did suggest other factors to look at, including neurophysiological effects of the injury, psychological vulnerability, self-awareness of the deficits, and social influences. Similar thing with the injury location impact on psychiatric symptom development, in that in the book it only talked about depression and the correlated lesion site, which is listed in the chart. It did not talk about other disorders and the correlated lesion site. It did mention about the disturbance in neurotransmitter system can create depressive symptoms. Again, it's pretty much depression focused. So next we're going to talk about why the TBI population is more likely to develop these psychiatric symptoms. So here I listed a few Axis 1 type of psychiatric disorders, which are the clinical disorders such as depression, bipolar disorder, anxiety disorder, and schizophrenia. And we will talk about the Axis 2 disorder in the next slide. So for depression, it's the most common Axis 1 disorder. It may be related to the location in the serotonin levels, as we have discussed. It was found that people with a TBI are at a higher risk than the general population. It was about 44% versus 5.9%. For bipolar disorder, it usually comes with behavioral swings associated with the mood instability. The prevalence for the TBI population is about 4% compared to the 0.8% in general population. And for the anxiety disorder and panic disorder, the anxiety can be the result of the psychosocial response, or it can be the biological result, like the brain damage or the neurotransmitter system damage, or it can be both. And patients with anxiety and depression are found to perceive their illness and their impairment level as far more severe than they actually are. And then the schizophrenia, the symptoms can include delusions, hallucinations, incoherent speech, catatonia, avolition. Patients are found to be 2 to 3 times more likely to develop schizophrenia after acquiring TBI. So for Axis 2 type of disorder, it includes the personality disorders and intellectual disabilities. So for the organic personality disorder that we sometimes see in patients with a TBI, it refers to patient presenting with a personality change, including apathy, affective lability, uncontrolled emotions, and aggression. The most common types of the personality disorders in patients with a TBI are avoidant, paranoid, and schizoid. At this time, it is hard to confirm that personality disorder is caused by TBI, but it is likely that TBI can exacerbate certain personality components or behaviors. So this is probably the easiest slide among all of them. I try to create the slides according to the learner's outcomes. And so one of the questions asks, how do you differentiate mania secondary to TBI versus mania? So the answer is that the mania secondary to TBI has specific symptoms, such as increased aggression and less euphoria. So what are some complications for rehab, community return, and independence with these psychiatric symptoms? The individual may become increasingly aware of the changes in their functional abilities. They may become frustrated due to the change in their abilities. They may experience the mood instability, and they may distance themselves to cope with the personality or behavior changes. This will impact their participation in rehab with increased behaviors such as aggression, apathy, withdrawal, and it may impact their functional independence and also community integration with the ongoing psychiatric symptoms. And that's it. And that's my presentation. Thank you for listening, and thank you for accommodating me not being there. I did try my best. Some of the information from these two chapters are not very clearly organized or straightforward. I tried to do my best, making it make sense. But if you have more questions, please email me. I'll try my best to answer it, or we can try to figure it out together. If you hear something funny in the background, it's my husband. He has been very cooperative. I appreciate that too. Thank you very much. Have a good one.